Today we'll be talking about sports-related concussion with a focus of management on the field. I know we might all be coming from slightly different levels of experience. So I tried to make sure that this would be a presentation that would make sure that we are all on the same page about how we should address any concerns for concussion on the field. And so forgive me if you already know most of the information, but hopefully everything is pertinent, or at least will help us to answer any questions that coaches, players, or parents might have even on the day of injury when we discuss some of the office side or later management parts of concussion. We can go to the next slide. So I have no disclosures or conflicts of interest. So we'll talk about the definition of concussion, the importance and epidemiology, as well as a little bit of how concussion cascade happens, how we make the diagnosis and eval, especially on the field, a little bit of management expectations for return to play and some of the concerns for complications. Next slide. Go ahead, next slide. So a concussion, the most difficult part probably about discussing concussion is coming up with a definition that everybody agrees on, and it's a pretty complicated definition. Most of the time when referring to the definition of concussion, we'll refer to the International Conference on Concussion in Sport. There's been 5 different renditions of this. Zurich was the 4th generation, which has been the one that I have most commonly seen cited, but in Berlin in October 2016, we updated this. So sport-related concussion is often defined as representing the immediate and transient symptoms of traumatic brain injury. It's sometimes considered to be a subset of TBI, or termed mild traumatic brain injury. A possible update to be provided at the 6th International Conference. I just included this in here because it was scheduled to be in 2019 and then moved to 2020 in Paris, and now it's delayed until 2022 because of the pandemic. So just like everything else in life. Next slide, please. So Berlin expert consensus guidelines say that sport-related concussion is a traumatic brain injury induced by biomechanical forces. And there are common clinical defining features, which include it may be caused either by a direct blow to the head, face, or neck, or other impulsive force transmitted to the head. Typically results in rapid onset of short-lived impairment of neurologic function, resolves spontaneously, and signs and symptoms may evolve over a number of minutes to hours. Sport-related concussion may result in neuropathologic changes, but the acute clinical signs and symptoms largely reflect a functional disturbance rather than a structural injury. This means that there's generally no abnormality seen on standard structural neurologic images, and is why we do not need imaging in a standard concussion evaluation. Neuropathologic changes are possible. These can be seen on functional PET scan, but obviously is not what we're doing for evaluation for concussion. Results in a range of clinical signs and symptoms, which may or may not involve loss of consciousness. Resolution of the clinical and cognitive features typically follows a sequential course. In some cases, symptoms can be prolonged, and the clinical signs and symptoms cannot be explained by drug, alcohol, or medication use, other injuries, or other comorbidities. Next slide. A slightly simpler definition can be found in the American Medical Society for Sports Medicine 2019 position statement. So concussion, again, is defined as a traumatically induced transient disturbance of brain function that involves a complex pathophysiologic process. It's a subset of mild traumatic brain injury, which is classified based on acute injury characteristics and less severe end of the brain injury spectrum. And again, clinical signs and symptoms can't be explained by something else. The one thing about this specific concussion, or this specific definition, even the Berlin definition, is there's even debate whether we should consider concussion mild traumatic brain injury, or if it's a completely separate injury than traumatic brain injury, but that's definitely still open for debate. Next slide. So why should we care about concussions? Go ahead, next slide. It's difficult to determine exactly how common concussions are, whether it's mostly because of misdiagnosis or lack of standard reporting, or a combination of everything, or even the fact that concussion is really diagnosed based on symptoms. And so we have to have honest symptom reporting in order to be able to recognize all of the time. But it's estimated that between 1 and 1.8 million sport-related concussions occur per year, just in ages 0 to 18. 50% of high school sport-related concussions are not related to organized sports. Only 20% occur in organized team sports. And as many as 50% of concussions may go unreported. 2 to 15% of athletes in organized sports will suffer a sport-related concussion per season of participation. So it is definitely a pretty prevalent injury occurring across most sports. Of course, differences depending on particular sport characteristics. Go ahead. So with NCAA injury reporting data, there's definitely several different categories of years that you can look at, but the NCAA has a very good system for recording these things. So as long as the school is entering their data like they should, these are pretty accurate numbers for concussions that are diagnosed. So I went ahead and used them as representative. So total athletes competing in all sports in NCAA reporting from 2011 to 2014 were 32,000 athletes. There were 1,400 concussions, and that equals out to 4.4% of players per season will have a concussion. The highest rate of sport-related concussion is reported in football, so that's a rate of 5.3% of players per season. However, this is mostly because the largest number of college athletes play football, so just a higher rate because we have more players. The highest incidence occurs in other sports. Traditionally, we've quoted women's ice hockey as being the highest incidence, but in these particular years for NCAA, it was actually men's wrestling that had the most concussions. And that's definitely a sport that maybe we don't pay as much attention to as being high risk. So I found that very interesting, and it's something we should be paying a little bit more attention to, I think. So that was 7.9% of wrestling athletes per season suffered a concussion. Men's ice hockey was at 6.9% per season. Then women's ice hockey, 7.2%, and women's basketball, 5.3%. These particular incidence rates help to highlight one of the other things that is true about concussion. In similar sports with similar rules, females generally have higher rates of sport-related concussion than males, and that's evidenced by the ice hockey data there. Go ahead, next slide. So why is this important? More than $60 billion was spent on TBI in 2000. It's hard to find really consistent updated data since that time, but that is, of course, across all traumatic brain injury, not just looking at concussion. So some of those much more severe than concussion injuries. It's estimated that for any traumatic brain injury, the lifetime cost of lost time from work and medical costs and everything for one patient is $76.5 billion, and that's in 2010 dollars. The estimated cost that we have for a concussed athlete, there's only one study that I could find. It was a retrospective study of just 144 concussions in one area. It was about $800 per concussion per athlete. So still a relatively big cost per athlete, especially given the wide range of different traumatic brain injuries we could have. Also, of course, lost time from school, lost time from sport. Student athletes often are treated with at least 1 day of cognitive rest. Their symptoms can take significantly longer to improve. And as they have cognitive symptoms, they can definitely have impairment in quality and efficiency of school performance. I have had plenty of athletes who have had difficulty catching up at school with a severe concussion. And we have to be considering what this means to our athletes, especially in high school or college. Average return to sport is highly variable. There's a handful of different studies looking at this. If you look at NCAA football studies, the first study suggested 6.7 days as average return to play. There was a larger study, the CARE study, not too long ago that showed 16.1 days on average. We commonly quote 7 to 10 days for our athletes, but I think looking at the data, we really see that this is going to be a lot longer on average for mini concussions. In a military study, it was as long as 29.4 days before military recruits who suffered concussion were back in full activity. It was slightly less for military NCAA or military college athletes at about 26 days, but still significantly longer than the timelines we usually quote. The risk of long and short-term morbidity, of course, we have significant complications like chronic traumatic encephalopathy, second impact syndrome, post-concussive syndrome to be concerned about in the long term, as well, in addition to just those short-term concussion losses. And then medical legal concerns for us, of course, the concern for human injury and loss, but also the monetary cost of a missed concussion with a resultant injury and death that we can be responsible for. Go ahead and next slide. So how do concussions happen? We'll talk next about the mechanism. You can go to the next slide. Highly variable, but a concussion typically results from either forces imparted directly to the head, forces transmitted indirectly through the neck. So a force that results in a rapid linear or rotational acceleration and deceleration of the brain is usually what brings on, is the actual mechanism of causing a concussion. There's multiple theoretic thresholds about how high these forces need to be. There's numbers quoted about a threshold between 60 Gs and 90 Gs, but we have not found any specific number to be a reliable indicator that there's going to be a concussion every time, or that you do not have concussion symptoms underneath that level. Recent data with significantly higher forces were documented without concussion, as well as concussions at lower forces. So there's currently no specific known threshold. Next slide. Rotational acceleration has been suggested to be an important role, more so than linear acceleration. But when we look at UNC Chapel Hill, the real-time helmet accelerometer study data, top of the head impacts were much higher risk for concussion, and most had more postural stability deficits. The top of the head impact results in 6 times generally more forces, greater than 80 Gs. So part of what we might be looking at here is just the exact forces that come along with those top of the head linear impacts as opposed to rotational forces. Rotational forces have definitely been seen to be more at risk in animal studies, however. So that translation of acceleration from a hit to a face mask or the side of the helmet, fall on the back of the helmet, are most frequently associated with concussion when we look at prior observed footage. The head down position in a striking player results in that high force transmission, as I was saying in that Chapel Hill data. So again, in the Chapel Hill data, there's a wide range of magnitude. 60 Gs to up to 168 Gs was the top force recorded at the time I quoted this data, which I will admit was multiple years ago, but there was no relation between impact location and magnitude on the severity of symptoms. And there is some question about the reliability of the data coming out of Chapel Hill. Recent reports showed that they withheld some of the data regarding athletes with confounding diagnoses or pre-existing conditions such as learning disabilities or ADHD. So the likelihood of who had more severe concussions related to modifying risks, which we'll talk about in a little bit, might be questionable from that study. The incidence of concussion is definitely seen to be higher in games than in practice, and anticipated impacts seem to produce lower impact forces. This was shown in a youth hockey study. So in that same study, higher translational and rotational forces in infraction hits, and those hits tend to be hits that players don't see coming. And so if you're able to prepare for a force, you might be able to stabilize your head better and reduce some of that force, but we don't completely understand why that data was different. Go ahead, next slide. So really quickly on the neurometabolic injury of concussion, this is super complicated and I'm not going to pretend that I can explain it really well. So this is the super small basics. Concussive force results in nonspecific and very fast depolarization through potassium channels. This results in a release of glutamate, which is definitely one of the markers that we've seen that we can test for in concussion, but we again have no specific test that's definitive at this time. So the release of glutamate exacerbates the potassium flux through receptor activation, including NMDA receptors. And this massive excitation is followed by relative neuronal suppression, which affects diffuse areas of the brain, which is why we can see symptoms across many different aspects of neurologic function. This is termed spreading depression. In an attempt to restore hemostasis, we use extra ATP and glucose, and this requires increased glycolysis, leading to increased production of lactate. Lactate accumulation results in neuronal dysfunction, which can be acidosis, resulting in membrane damage, and altered blood-brain barrier permeability, which is the theory of how cerebral edema occurs and may have increased vulnerability to repeat injury, which is what is second impact syndrome. And then cerebral blood flow decreases in this setting, which exacerbates the energy crisis because, of course, we have less inflow of those building blocks. So cerebral glucose is diminished for 5 to 10 days in animal studies, but we've seen it demonstrated to last 2 to 4 weeks in PET scans on humans. So those animal studies definitely don't seem to show the level of injury that we can have in humans. And that might be just a function of how different how we have different complexity in our brains. Next slide. So diagnosis is challenging due to multiple factors. As I said, it's based only on clinical assessment. There's a lack of validated objective diagnostic tests, both in as far as performance tests and blood test imaging, everything. So we rely on self-reported symptoms only. The confounding symptoms caused by other common conditions make it harder as well for us to be able to determine who has a concussion and who does not, because it looks variable in every athlete and it can look variable with every concussion in the same athlete. There are very non-specific symptoms. These symptoms can be delayed or unrecognized by the athlete themselves, or unrecognized by those around them, as well as being part of concussion cascade. And the symptoms definitely can be represented through other syndromes, and we can just term them to be part of an athlete's personality or what have you. Preseason baseline testing may be helpful in high-risk sports. So we have a ability to compare an athlete's normal to their post-injury. But there's considerable normal variation in test performance with repeat testing in non-injured athletes. There's multiple theories as to why this can be. One might be what mode of testing you're choosing, the location of testing, and particularly when you look at a baseline versus a post-injury or a sideline assessment, we're talking about often we're looking at significant variation in the surface that we're testing on. So it can make a difference in our balance testing, as well as what's going on around the athlete, how loud it is, lights on the field, things like that. And so doing it in a quiet room versus on the sidelines definitely can result in different outcomes, even for a non-injured athlete. And then there's also the theory of getting better at the test as we learn it. So every repeat test might show improved scores for any given athlete. Go ahead, next slide. So sideline evaluation, the reasons that we need to look for immediate prompt removal from play. These can be reported or directly observed. So any loss of consciousness is absolutely a reason that an athlete needs to come out, be evaluated, but loss of consciousness means that an athlete should not go back in the same day, no matter what. An impact seizure, tonic posturing, gross motor instability, confusion, amnesia. So I'm sure most of us or all of us have seen those athletes that either go to the wrong sideline, are going to the wrong side, offense, defense, are going around in circles, don't know where they're supposed to be, just look confused. Those are some of the things we need to be looking for. Absolutely. So like I said, the above indicate the removal from play, at least for the remainder of the day. Any healthcare provider familiar with the athlete is best suited for evaluation, but obviously we don't always have the benefit of knowing all of our athletes ahead of time. Evaluations should be performed in a distraction-free environment with adequate time. So obviously some sports don't allow us to really have adequate time. Soccer, particularly, if an athlete comes out, they're out, they can't go back in. And depending on what level you're taking care of soccer players out, that can be true just for a half, or it can be true for the whole game. And so definitely it's delightful to be covering soccer and having coach yelling at me for every second that I'm trying to figure out if an athlete has a concussion or not on the sideline. So if sport-related concussion is suspected but not diagnosed, removal from play and serial evaluations are indicated. Again, starting with that same day. If you're cleared of sport-related concussion, you can suspend any testing and allow immediate return to play. So only in an athlete that you don't have concern for having an actual concussion and does not have these specific things as what you brought them out of the game as can return to play the same day. Go ahead, next slide. Signs and symptoms are wide and variable, but generally can be grouped into 4 different categories. So the physical: headache, nausea, vomiting, balance issues, dizziness, vertigo, visual problems that can be blurry vision, trouble focusing for the most part. However, in acute concussion, absolutely don't be afraid that if an athlete's seeing spots, seeing stars, having, especially an athlete with a history of migraine with aura, having things like scintillating scotomata, that fuzzy TV, like squiggly line type of appearance, or even kaleidoscope visual issues, those are all absolutely part of concussion. As long as they don't have other neurologic issues, you can consider that to be part of concussion only, as long as they resolve as their concussion symptoms improve, and they don't need specific other evaluation for those by themselves. Fatigue, sensitivity to light and noise, numbness, tingling, that dazed, stunned, confused look. Sleep can definitely be affected in athletes. They can be drowsy. I'm sure, again, we've seen those athletes on the sidelines. We have trouble keeping awake. If we can't keep them awake, that's a reason for emergent evaluation. But they can also have difficulty falling asleep later, sleeping more than usual or less than usual. Cognitive, that feeling in a fog, feeling slowed down, difficulty with concentration and remembering, being confused, slow to respond. So particularly for athletes that we know, really important for us to pay attention to how they're answering questions or how they're repeating questions, to buy themselves some time for us to know that there's something going on, especially with our highly intelligent athletes, because they really know how to kind of mask that this is going on. Not necessarily to be purposefully hiding these symptoms, but it's just naturally what we do for most of us to kind of save face, I would say. Emotional irritability, sadness, definitely we can see suicidal ideations in patients with concussions, more emotional liability. A lot of parents get really scared by this, like they're looking at an athlete in front of them that is nothing like their kid. And I just try to make sure when I see that, it's generally moms, when I see that look of concern, like I don't recognize this person, just remind them that being highly emotional, crying when we don't cry, is absolutely part of concussion symptoms for a lot of athletes. And then you can also have some significant nervousness or anxiety in athletes that usually don't. Next slide. So other possible signs: that vacant stare, delayed verbal expression, inability to focus, disorientation, emotionality out of proportion to circumstances, like I said, and then those concerning tonic posturing and convulsive motions. Next slide. Any athlete with one or more of the following should be referred for immediate advanced evaluation with activation of the emergency action plan, possible EMS transport. So prolonged loss of consciousness. If you have a few seconds, less than a minute, definitely not something to be significantly worried about. But any really long loss of consciousness, you're not able to wake that athlete, could be an indication of a severe TBI, and they need to be transported. Severe or worsening headache, repeated MSS, a declining mental status as you're evaluating them, especially a very quick decline in mental status, any focal neurologic deficit. So like I said, not those subjective eye type symptoms, but if you don't have normal extraocular motions, if you have numbness, if you have weakness in one place, are not able to walk, things like that should be evaluated. And then suspicion of significant cervical spine injury. So just like always, if we take a big hit and they're down on the field, we need to do our C-spine clearance before we get them up even and off the field before we're evaluating for concussion. Next slide. So SCAT5 and the child SCAT5 are generally the evaluation tools that are commonly recommended. They have standardized approaches to sideline evaluation. They incorporate the multiple domains of function that help us to determine that an athlete is concussed. This is important both so we know where the athlete's symptoms are to start with and can monitor in serial fashion, but also because an athlete may only show symptoms of concussion in one domain. So they might be really great at memory, but not be able to not be able to balance it all. So important to look at all of those domains, and they're widely available at no cost. But ultimately the things that are important, regardless of what evaluation approach you use, are that you have a brief neurologic exam, you document the symptoms of the concussion, you have a brief cognitive assessment. And again, I mentioned before, if we're using the same cognitive assessment all the time, there's a learning effect with repetition, which is why on the SCAT5, there's like a list of 5 different options that we can use different ones each time we do the test. Combining tests for multimodal assessment may increase sensitivity and specificity. And then a balance assessment is important as well. Next slide. So just really quickly, I took some screenshots of a SCAT5 in case anybody's not familiar with it. Again, it's laid out really nicely in that it has, even if you are not really comfortable with concussion, it spells out red flags for us and it walks us through all of the different steps. And so as long as you follow the SCAT5, you're going to have a really good idea of what's going on by the end of it. So step 1, it just reviews red flags for us. So all the things that we already talked about that would be concerning for something other than just the standard concussion. Next slide. Then just documenting observable signs, the Maddox questions, memory assessment. I know that these are small, but you can pull up a SCAT5 and look at it to see all of the little detail. But so 5 basic questions that we ask athletes just to get a better idea of where they are in the moment. Like what half is it now? What quarter is it now? Who scored the last? Just making sure that they know what's going on there, looking for retrograde amnesia more than anything. Questions don't need to be the exact Maddox questions on the SCAT5. They absolutely should be tailored to be sport specific. So if you're not at a football game, make sure you're asking questions that apply to whatever sport you're at, not to football. So step 4 is the Glasgow Coma scale. So any athlete who has a GCS of less than 15 should definitely be have emergent evaluation, not necessarily transported by EMS, depending on where it is. But we need a normal GCS to know that we just have concussion. Cervical spine assessment. So again, ruling out that C-spine injury. Next slide. So symptom evaluation, the athlete can do this, or they can be asked these questions. Cognitive screening, so orientation, what day is it, what time is it, what have you. Immediate memory, so there's a list of 5 words and a list of 10 words on the SCAT5. And as I said, there are different groups, so you can use different ones for each time you assess the athlete, or at least don't always use A for every single athlete you assess. And then concentration, so ability to list digits backwards. Reminder that just because an athlete can't do 6 or 7 serial digits backwards, that this does not necessarily mean they're concussed. Again, knowing their baseline is important, but most of us are going to have trouble with strings of numbers more than 7. And when we add going backwards, those longer ones definitely become difficult for all of us, even if we're healthy. And then months in reverse order. The number one thing I would say about this, if you've never given a SCAT, and never ask somebody to say the months of the year in reverse order. You might want to ask them to say the months of the year in forward order first, because you'd be surprised how many athletes can't do that normally. So having a parent that can tell you that can be helpful too. I've definitely had that happen more than once, where the parent's like, I don't think they say that right ever. So next slide. Neurologic screens, so looking for those concerning reasons to get higher level care, balance examination, and then delayed recall, asking for those words that you asked for immediate recall and documenting the time, how long later it is. And then the decision. So you can put all of the data that you have, what the scores for everything are, into one place and have it all. If that's the way your brain works a little bit better, you can have it all right there in front of you to have a little bit easier decision based on how many things are abnormal. And then it's a nice little checkbox that just says, do you think this is what's going on? And then what are we going to do going forward? Next slide. The reason I really like SCAT5 is that it has concussion injury advice on a single page that you can tear off and you can give to parents. So it tells us the most important things about what we do initially after the injury, like avoiding alcohol and substances that can alter the symptoms that we're seeing with concussion as well. And things like, do we need to wake them up or do we not? And just for clarity, we do not need to be waking our athletes up who have concussions. Worried parents can be checking in on them and making sure they're breathing, but they shouldn't be waking up. Sleep is important for recovery. If you have an athlete that you're concerned about letting them go to sleep, they should be evaluated further before going home anyway. So no reason after concussion that we need to be waking up our athletes. Next slide. And then there's also a page, again, if you haven't done the SCAT5, there's two pages, one page front and back, that describes exactly how in standardized fashion you do every step of the SCAT5. So it's very nice that it's all encompassed in one document for you. Next slide. And then it also spells out return to play and has some suggestions for how we can return athletes to school even before they're completely recovered for the concussion. So again, just across the board, pretty much everything in one document. If you don't have a SCAT5, consider looking at it. It might be a really helpful resource so that everything is just in one place for you. Next slide. Office evaluation. So just quickly, for those of you who are not going to be clearing an athlete in office, obviously you don't need to know too much of this, but it's helpful to have some sort of idea in case you're asked. So any athlete with a diagnosis of sport-related concussion. So if they're cleared that same day, you don't think it's a concussion, they don't have to go to a healthcare provider for clearance. But anybody else, anybody who's entered into a so-called concussion protocol should be evaluated by a healthcare provider. So we should get a comprehensive history and neuro exam, symptom checklist, can track symptom trajectory and resolution of symptoms, confirm the diagnosis of sport-related concussion. In order to confirm the diagnosis in the office, they do not need to have symptoms at that time, but they need a clear mechanism consistent with concussion and characteristic signs and symptoms, as well as the characteristic time course. These can be resolved and testing can be normalized by the time of office evaluation. And if they are, that means we can start getting them back to school and play. Next slide. So risks and modifying factors. Who's more likely to have a concussion? If you've had a previous concussion, you're 2 to 5 times more likely to have a repeat. You may have more symptoms immediately post-injury, and you may have more severe symptoms and more prolonged recovery with every consecutive concussion. Female gender is definitely more likely to have concussions, at least based on data. We don't know exactly why this is. There's some question about hormonal influence. There's question about honesty and reporting. And there's also, I don't like to talk about this too much because it kind of buys into the whole women are more anxious and everything's about anxiety in women. But there's definitely some question about women just being more aware of what they usually feel like, knowing when things are different and being more concerned about their health overall. And so therefore reporting more, and that's why they're diagnosed more. The risk for higher number, more severe and longer symptoms, again, in female gender. So younger age, we probably have a higher risk for concussion, and that can be also accompanied by catastrophic injury. One theory about why younger athletes have higher risk of concussion is that their brain is still developing. And so when we have a developing brain, if we have that lactate buildup and glucose deficiency, that we're going to be even more susceptible to it. But also the reason that they might get more concussions is that neck strength, especially in helmet wearing athletes, may not be strong enough to hold our head and our helmet weight easily. And so less control of our head, more risk of forces inside the skull. And then sport position and style of play are also risk and different modifying factors. So think of an offensive lineman who gets hit every play he's on the field versus a kicker who almost never gets hit. Or just a really aggressive athlete, somebody who's diving for balls and jumping for balls and leaving their feet a lot. They're much more likely to have their head run into something or have a hard fall that could increase their risk of concussion than an athlete who plays the same sport or even the same position who doesn't have the same tendencies in their game. Next slide. So these are more things that complicate diagnosis of concussion or clearance from concussion, as opposed to truly make it more likely to having a concussion. So mood disorder complicates diagnosis and management because the emotional aspects of concussion can make it more difficult to see where the athlete is at baseline versus where they are in determining what's concussion related and what's their normal. Learning disabilities and attention disorders like ADHD may be associated with increased cognitive dysfunction, more susceptibility to symptoms in a concussion. So in theory, their concussion is more severe, but probably because they're starting from a place where they're not neurotypical to begin with. And therefore prolonged recovery, again, potentially because we have difficulty determining what is actually the athlete's baseline versus what's impaired. Impaired performance on neuropsychologic testing in general for ADHD or other learning disabilities. So especially in those prolonged symptoms, if we're getting formal neuropsychological testing, again, it can be difficult if we don't have a baseline to tell if this is just concussion related or if it's their normal. Migraines, possible risk factor directly for obtaining a concussion, but particularly prolonging recovery and the increased risk that migraine or that concussion can cause migraine, which is called a post-concussion migraine. Next slide. So what do we need to do? Management and return to play. Next slide. Immediate management, as we said before, no return to play for any athlete with symptoms suggestive of sport-related concussion. The cornerstone of early treatment is rest, and this usually includes at least one day off of school, generally because you don't know, especially for Friday night games for football, we don't know what they're going to feel like on Monday. So better to just give them a blanket excuse and make sure they're covered and they don't have to sit through a day of school and make their symptoms horrible. But that being said, you can tell them if they're feeling great on Monday that they can go to school. Avoid screen time, mostly because screens, as you probably know, are not static images. They are series of pictures that our mind puts into video or flashing lights. And so that is more work for the brain, can definitely exacerbate symptoms, let alone bright lights can exacerbate symptoms. This includes phones. Our athletes really don't like it when I tell them that they shouldn't be texting all weekend after they have a concussion, but that's definitely something that's important to tell them. Consider avoidance of watching games or practice. So if they are really sensitive to noise, sensitive to light, are really distractible and just having trouble just sitting there on the sidelines and it's making their symptoms worse, get them off the sidelines. Don't have them sit there and watch practice or the rest of the game. Let them go rest. And then again, note for school accommodations. Physical exam or limit physical activity initially. Keep everything below symptom exacerbation so they don't need to lay in bed all day and shouldn't, but make sure they're not running, jogging, or particularly putting themselves at risk for another head injury. There is data that physical activity, cardio at low levels that does not increase their symptoms may actually speed recovery. So that can be something used in athletes, particularly who are having trouble recovering. And then driving, consider if a concussed athlete should be driving. You might want to tell them just until they have an office evaluation or we are doing serial testing that they shouldn't be behind the wheel, because of course, if they have slowed reaction times and slowed cognitive responses, they're probably not the best person to be in charge of their own life and other people's lives in a motorized vehicle. Next slide. Preseason considerations, again, pre-participation exam is a time that we can ask for concussion-related history. Do they have a history of prior concussions? Do they have some of those medical histories that are modifying factors? And considering should clearance be withheld for an athlete with multiple concussions or significant risk factors, or at least do we need to modify what we're doing for them so we pay special attention to what's happening with them? In my case, I usually don't tell anybody that they cannot play again if they've had a certain number of concussions, but I have long discussions with family and the athlete about what the risk is and why we are worried about multiple repeat concussions. Baseline testing considerations, as mentioned before, that there's learned behaviors, especially consideration for the fact that athletes might purposefully take a baseline so that they feel like they could perform better on a post-injury, and we can hide a concussion for us. Ultimately, whatever you're using for baseline testing, make sure you evaluate that test for validity, particularly on things like impact testing, other computer assessments. They have a validity ratio, and if you have a baseline that does not reach that, in impact it's a 0.2 validity. If their score is below 0.2 on time versus accuracy, then you know that something's going on. It's not a valid test and you can't use it for comparison. And then make sure wherever you're at has an emergency action plan, whether it's your personal emergency action plan for like you're the athletic trainer, school district, what have you. If you are a position covering at a specific school, make sure you talk with the athletic trainer and make sure that you guys are on board about what the overall concussion management protocol is and what EMS transport looks like and how we initiate that, that timeline. Also consider a liaison for school accommodations. A preseason is a good time to figure out who's going to be the person at school if we have athletes with concussions. That can really help make sure that we're getting them taken care of with accommodations. Next slide. When do we get neuroimaging? So GCS less than 2 hours after injury, suspicion of a skull fracture, severe or worsening headache, pronounced amnesia, seizures, focal neurologic findings, persistent repeated emesis, significant drowsiness, you can't keep the athlete awake, significant irritability. So that's kind of more like, obviously it's based on each athlete and what you know about them, but also consideration for their risks to themselves if they have significant irritability, worsening symptoms, and then failure to improve as expected. So neuroimaging can happen on day of injury, or sometimes we do it very much later in concussion if someone's not improving at all, multiple weeks or a month later. And then loss of consciousness longer than 30 seconds may have a higher risk of intracranial injury. So that's definitely the timeline you'd consider advanced imaging for an athlete early on in the injury course. Next slide. Medications, ultimately, there's not a lot of medical or medication management for concussions. We do want to tell athletes to avoid drugs that alter mental status. We just don't want to complicate understanding what is related to concussion and what might be something else. Avoidance of medications that may mask symptoms. In general, treatment for headache is okay, but consider avoidance of medications that increase bleeding risk, so aspirins and NSAIDs. And then no specific evidence in human trials of decreased time to symptom resolution, despite many animal studies that have shown improvement with B vitamins, omega-3s, vitamin D, ketogenic diet. There's an entire list of different supplements and ways to supposedly reduce your symptoms from concussion or speed recovery, but none of these have been proven out in humans to this point. Next slide. So prolonged symptoms, headache, acetaminophen is definitely preferred and can be helpful for headache control, but you want to make sure that you are taking into account whether the athlete has a headache or doesn't have a headache, as opposed to whether it goes away with medication. So if they had a headache that they needed to treat, that's still something we need to consider as a symptom. And then migraine sufferers who might be having post-concussion migraine, triptans can be helpful to control their symptoms. And considerations for physical modalities, osteopathic manipulative treatment, massage, physical therapy for neck pain, ice, all sorts of different things. A lot of athletes get continued headaches because they have neck pain from their concussion that causes stress headaches, as opposed to a true headache from from their concussion itself. So absolutely, if we're focusing on some of those other physical aspects, sometimes we can get them better faster as well. Sleep disturbance, you can let them know that, and this would not be like first night, but if they're having sleep issues later on in recovery, melatonin and Benadryl can be helpful for sleep, but avoid sedative hypnotics as they worsen symptoms. And then cognition, there's definitely a role for stimulant medications for improved cognition in athletes with prolonged symptoms, particularly those with a history of ADHD. So even those ADHD athletes who are not typically on stimulant medications, if they're really struggling post-concussion with prolonged symptoms and a lot of cognitive issues, more trouble with school, definitely having a talk with the family about whether starting a stimulant medication for their ADHD could absolutely help both speed their recovery because they're not struggling as much, but just make sure that they don't get as far behind. Next slide. Return to school. There's no standardized guidelines, but cognitive stress may absolutely increase symptoms. So generally recommend no school until an office evaluation, unless that's going to be significantly delayed. Cognitive deficits can persist despite the resolution of other symptoms. So if a student athlete is telling you that they're really struggling with getting work done and struggling with school, even though they don't have headache and they don't have blurred vision and they don't have sensitive light and all those things, it should absolutely be something that we consider and we take at face value. Obviously, people can try to game the system, but I always tell my athletes that until they are back to full student duties, that they don't get to be back to athlete duties because they're a student athlete. The student's first for a reason. But so student athletes can require accommodations upon return to school. This can include reduced workload. I always ask teachers to give them assignments that just let them show that they can do the work, as opposed to necessarily busy work or having to repeat 30 math problems if they can prove it in 5. Extended breaks and rest times might be required. A note that says that they can go to the nurse and lay down for a little while can keep them at school more instead of having to go home all the time. Extended test times or due dates. In general, any significant standardized testing or big tests, big essays, things like that, I try to make sure my athletes know that they should ask for extended time or a delayed due date before they do these things, because it's much harder for me to fix a bad grade after they perform poorly because of a concussion. And then reduced hours at work or reduced hours at school potentially. So taking just a half day instead of a full day. And in the case of high school athletes, considering that we don't always go to morning classes and always miss afternoon classes if we can't do an entire day at school. Recommend no return to play until athlete is at their cognitive baseline though. Next slide. So return to play guidelines. You must have complete resolution of symptoms before attempted return to play. And athletes should be free of symptoms at rest and after exertion before going back to their sport. Generally accepted 5-step return to play, which is spelled out on the SCAT-5. Step 1 is no activity, which is just recovery time. So that's while we were holding them out completely. Step 2 is light aerobic exercise. So just getting that heart rate up a little bit, testing how increasing that heart rate, their brain responds. Step 3, sport specific exercise. So add some extra movement side to side. Step 4, non-contact training drills. So increasing the exercise, the coordination, the cognitive load that is required to do these things and seeing how we respond to that. Step 5, full contact practice. So restore the confidence of the athlete, assess their functional skills, make sure they're ready for game speed activity. And then last is return to play and games. They're not really completely cleared from concussion until they've successfully competed in a competitive environment, participated in a competitive environment. So 1 stage per day. We should not be combining stages. The one exception I'll make to that, if you're documenting it as such, is that if an athlete has been doing some light aerobic cardio to help speed their recovery, then whether you say they've already completed step 2 on a previous day or let them do step 2 and step 3 at the same time, that would be my one exception to that. So stop if the athlete develops any symptoms at all, rest until symptoms are completely back to where they were. And you must complete a stage symptom-free before progression. If you have any symptoms, you're not able to repeat a stage, then you need to go back to the last stage that was successfully completed, repeated before continuing progression. Next slide. last thing about that, individualize the progression. So just because there's a specific return to play spelled out on SCAT-5 that's very football specific doesn't mean that's how every athlete should be treated. Sometimes you need to really come up with specific skills and things that should be tested for a ballerina, for example, as opposed to a football player. So potential complications, second impact syndrome is definitely the one that is probably the most concerning, because it can result in immediate death. Although I think all of these complications are concerning in their own ways. So second impact syndrome is diffuse cerebral swelling, occurs within seconds of a head injury if symptoms of prior head injury are not fully resolved, hence the second impact syndrome. Sorry for that little typo there. Pathophysiology is poorly understood overall, but again, thought to be related to that cerebral blood flow dysregulation and the neurometabolic cascade. So vascular engorgement causes increased intracranial pressure, which can result in brain herniation, coma, and death. Every time I give a concussion talk and we talk about second impact syndrome, I can pull up different pictures of athletes who are affected by second impact syndrome every single time. So when I first gave this talk in 2014, there were 17 confirmed cases of second impact syndrome, but that goes up every year. It's a true thing. So these are all athletes who have suffered second impact syndrome. Turan Moranik is the only one on this screen who's still alive after his second impact syndrome. He did recover. So next slide. Potential complications, post-concussive syndrome. So there's different ways that post-concussive syndrome is termed. Some people just call post-concussive syndrome the symptoms that we have after concussion, but most of the time we're referring to this, we're referring to the prolonged symptoms of concussion lasting for greater than 3 months. These symptoms can be strictly subjective or they can be objective. They're often non-specific, and they can be any combination of concussion symptoms, including just cognition or some of the emotional aspects. So it precludes return to play if we're still having symptoms, although there is some in professional athletes, sometimes they don't always follow that just because of their risk benefit ratio, I guess. But recovery may be enhanced by progressive exercise programs, vestibular therapy. Risk factors are increasing age of female athlete and non-sports related concussions. Next slide. Chronic traumatic encephalopathy. So this is definitely something that is a part of concussion discussion, but I want to remind everybody first and foremost that there is evidence that we can develop CTE without ever having a diagnosed concussion, and potentially ever having suffered a true concussion. This can be a series of micro injuries that lead to CTE as well. So again, those offensive linemen that are taking a hit every single play in football could definitely be at increased risk for CTE. Even if they never truly had concussion level symptoms, whether they were reported or caught or not, it could have just never been there. So develops decades after exposure to those micro injuries or repetitive concussions, variable symptoms and progression based on brain involvement. But it's a tauopathy in specific areas of the brain, preferential involvement of superficial cortical layers, and particularly the frontal and temporal cortices. So emotional dysregulation and difficulty with decision-making. Terry Bradshaw is a well-known example that's living, and he talks about his significant difficulty with memory, as well as multiple head injury history. But Junior Seau took his own life in 2012. Chris Benoit from wrestling in 2007 in a murder-suicide, and then Dave Jerson in 2011, and he left this note: "Please see that my brain is given to the NFL's brain bank," because he knew something was wrong and wanted to make sure that we learned from it. Next slide. So concussion prevention and legislation. So there's increased awareness overall, education regarding signs, symptoms, effective concussion, which results in improved recognition, and an athlete-centric response is important. Obviously, there's been NFL and NCAA rule changes about hits, like we were talking about with the NC Chapel Hill data. Those top of the head hits, that head down spiking, definitely more forces, increased risk of brain injury as well as catastrophic spine injury. So making sure that we're not allowing those hits. Independent observers in some sports, so a healthcare provider with concussion history who is watching the field and monitoring for any signs and symptoms, can pull athlete from the game for evaluation, requires full clearance before that athlete can come back. Strict officiating, officials can pull athlete from the game, enforcement of hitting rules. There is possible use of preventative gear, but there is no current gear that is proven to reduce the incident of concussion. Helmets don't protect us from concussion. Helmets protect us from skull fracture and other catastrophic brain injury, like skull, like I said, fractures, but do not prevent concussion. Next slide. So all 50 states have concussion legislation. It's spearheaded by the CDC. In Arizona, it was passed in 2011. Basically, it's the same parts that are in pretty much every concussion law, but school districts have to provide education to athletes, coaches, parents. They have to be concussion guidelines. There's mandatory yearly signed consent after information about concussion and head injury, immediate removal from play. But anybody can, in Arizona, anybody can ask for that. A healthcare provider, game officials, parents are all empowered to express their concern and remove a player and have them evaluated. Same day return to play only if a concussion is ruled out by a licensed healthcare practitioner. Clearance before return to play, subsequent day after, only can be done by a licensed healthcare professional after evaluation and prefer and with specific training. And then legal immunity for health are immune from civil liability taken in good faith. Of course, neglect. So just a reminder here, if you're getting paid either in the office or to be on the sidelines, this does not qualify to have immunity from civil liability. Ability to provide applies to private organizations using school athletic facilities as well as the schools, but does not apply to all athletic activities if not in school facilities. And then the AIA requires a 30-minute interactive online concussion learning module that's just called Brain Book. Next slide. CDC Heads Up campaign has lots of different fact sheets and posters and things like that. The AIA has a bunch of concussion related resources. There is, or at least was, Barrow Concussion Network and AT Still University had their concussion program. They provide Brain Book, which is still there, but there was free impact and balance testing to all AIA high school athletes previously. I was told by an athletics trainer friend that doesn't, that's not still in place, but the AZ ATA website says that it still is as of 2020. So I don't know, it might still be there, it might not, but next slide. And so in summary, concussion is a serious injury, but it does not require a direct blow to the head or a specific force threshold. It requires immediate removal from play. And so if in doubt, pull them out. If any concern for concussion, sit them out. Multiple evaluation tools are available. Become familiar with at least one. Consider carrying copies for documentation purposes, as well as informational handouts for parents, coaches, what have you. No same day return to play unless concussion ruled out by a healthcare provider. You need to have an individualized return to play. If you've seen one concussion, you've seen one concussion. Not every concussion is the same. If you don't know the athlete, use coaches, athlete trainer, parents for insights into what the baseline of the athlete is. And this last line is incorrect. Physician written clearance is not required for return to play for an athlete. It's a licensed healthcare professional. Sorry, that is a holdover from when I gave this in Alabama, but it requires a licensed healthcare professional to clear a player to return. So next slide. A list of resources, next slide. More resources, next slide. I welcome any questions.